So good morning, everyone. I hope I'm audible to all of you there. So can just somebody reply saying that I'm audible? I'm good enough. So I think first of all I would like to thank Sunita ma'am for giving me this wonderful opportunity, and I hope that these E classes are a wonderful addition to all your existing teaching schedule. So we'll be having this short quiz on the drugs which we commonly use on OPD basis in our day-to-day pediatric cardiology practice. Obviously, because of time constraint, it's not possible to include all the drugs, but we'll see most of the common drugs which we use. So okay. So let us guess this first drug. So this was mentioned in the writings of the Welsh physician way back in the 13th century, and received the botanical name about 300 years later. So initially it was used for the treatment of dropsy, and it was only later that its diuretic effect was ascribed to its cardiac action. So does anyone want to take a chance? Which drug are we talking about? And that's the flower or the plant from which the drug has been extracted. So this flower is named foxglove. So anybody? Which drug are we talking about? No clue yet. Okay, so let's proceed. So the drug is Digitalis. So coming to the next question, what is the mechanism of action of Digitalis? Does it involve activation of the sodium potassium ATPase pump, or does it involve activation of the sodium calcium exchanger pump, or is it because of inhibition of the sodium potassium ATPase pump or inhibition of the sodium calcium exchanger pump? Does anyone want to answer? You can just type in the number of the answer. For example, if it's one you feel is the right answer, just type in 1 in the chat box. Excellent. So number 3 is the right answer. That's inhibition of the sodium potassium ATPase pump. So as you can see in this video, so the channel on the left side of the screen is a sodium potassium ATPase pump, which exchanges 3 sodium ions for exchange of 2 potassium. So when Digitalis blocks this sodium potassium ATPase pump, there is a collection of sodium inside the cells, because of which it now gets exchanged for calcium through the sodium calcium exchanger pump, in turn increasing the amount of calcium available inside the cell and producing the multiple effects which we will discuss now. So it has direct as well as indirect mechanism of action. The direct action is on the myocardial cells and on the SA and the AV node. And then there is indirect mechanism of action which involves parasympathetic activation leading to sinus node slowing as well as increased duration of conduction all across the AV node. So the serum half-life is roughly around 36 to 48 hours. Is higher in premature neonates to the tune of almost 60 to 170 hours. Steady state concentration, if you just start maintenance dose, can be reached only after 7 to 10 days, that is 4 to 5 half-lives. So does digitalis cross the placenta? Anyone? Yes? No? Excellent. And what is the fetal umbilical cord venous level like? So let me answer that for you guys. So it's essentially the same as the maternal blood levels. And that's the reason that we use digoxin or digitalis to treat even fetal SVTs by administering digitalis to the mother. Coming to contraindications, so what are the absolute contraindications for giving digitalis or digoxin? Does anyone want to name a few of the absolute contraindications? Very good. So we have HOCM, DIG toxicity, okay. So which other conditions specifically you wouldn't want to give digoxin? So DIG toxicity, obviously you have already given digoxin, the patient has developed toxicity, so you don't want to continue digoxin or rather restart digoxin. But which are the conditions where you wouldn't really start or even consider starting digoxin? So one is, as Amitosh mentioned is hypertrophic obstructive cardiomyopathy. Next is a WPW syndrome, where digitalis can increase the conduction, the antegrade conduction along the accessory pathway, and in the presence of atrial fibrillation may cause it to degenerate into a ventricular fibrillation. Next is a high grade AV block, obviously because your AV conduction is prolonged. And relative contraindications include renal failure, hypokalemia, which can increase digitalis toxicity, acute myocarditis in premature neonates with impaired renal clearance, and along with other drugs which prolong AV conduction like beta blockers, calcium channel blockers, and amiodarone. So what do we mean by digitalis effect? So these are basically non-pathologic ECG changes which we observe when the patient is on digoxin therapy. So it includes a short QT interval, flattened or inverted T waves, and a hockey stick appearance of the ST segment, which is somewhat like this. So you have a short QT interval, and you can see that the T waves are inverted, and you have this sagging of the ST segment giving a hockey stick appearance. And when do we say that there is digitalis toxicity? So one is if your levels are beyond the therapeutic range. So therapeutic range now, the range has actually been brought down to almost 0.5 to 1.2 nanogram per ml, because the recent study has shown in adults that the hazards ratio for death increases if by 1.33 times if your levels are more than 1.2 nanograms per ml. So the older levels of 1 to 2 are no more considered as safe. So what are the mechanism or by which digitalis toxicities manifest? These are basically extremes of the mechanism of action by which digoxin acts. So there is increased excitability and decreased conduction. So what you see here is there are two ECGs, one at the top which shows ventricular bigeminy, and the one at the bottom. So the top, it's because of the increased excitability, and one at the bottom where you see that there is presence of ectopic atrial rhythm with anyone? Does anyone want to take a guess as to what type of ECG is that? So it's essentially a AV block. And then you can have patients presenting with symptoms related to the GI tract, including nausea, vomiting, anorexia, visual symptoms like blurred vision, halos around the light, and yellow-green discoloration, palpitation, syncope, dyspnea, and confusion, dizziness, delirium, and fatigue. So usually what you need to do is check the blood levels, make sure that the blood has been collected 6 hours after the last dose. If it's a mild toxicity, just temporary withdrawal of the drug should suffice. If it's a life-threatening toxicity, then digoxin antibodies need to be given. Presence of ventricular arrhythmias can be treated with potassium supplementation, lidocaine, phenytoin. If there is presence of AV block, then we need to give atropine, and some patients may even require a temporary pacing. I wouldn't really go through this. It's easily available. You all know probably dosing for digoxin. Coming to the next drug. So this is one of the most commonly used drug in our cardiac patients. One of the brand name for this drug essentially means that the frequency of giving this drug is every 6 hourly. So any guesses? Excellent. So basics or furosemide. So what is the mechanism of action? Okay, so it's a loop diuretic. So does anyone want to take a chance as to which exact channel does the furosemide act on? Does it act on sodium chloride transporter, or the sodium potassium chloride co-transporter, or is it the sodium potassium and hydrogen exchanger, or sodium bicarbonate transporter? Very good. So as you can see in this picture here, so this is a picture of the nephron where you can see the glomerulus. Then you have the proximal convoluted tubule where you have your sodium and bicarbonate transporter channel, typically blocked by the carbonic anhydrase inhibitors. Then you have your loop of Henle, and then the distal portion of the loop of Henle where you have the ascending limb along with the thick ascending portion. This is where your sodium, potassium, and chloride transporter is located. So this is responsible for absorption of approximately 25% of your sodium. Along with it, you have 1 ion of potassium and 2 ions of chloride also being absorbed, which also leads to proportionate absorption of water. So this is where your furosemide acts and blocks the absorption of sodium, potassium, as well as chloride, and including that much amount of water. So what happens is that much amount of sodium is present intraluminally, and which gets presented to the distal convoluted tubule as well as to the collecting duct. So we can see there is presence of sodium chloride co-transporter in the distal convoluted tubule, which are blocked by the thiazide diuretics, and you have the potassium and hydrogen, sodium potassium hydrogen exchanger channels located in the collecting ducts, so which may be responsible for loss of potassium, because if there is a lot of sodium present intraluminally, it gets exchanged for hydrogen and potassium ions in this collecting duct, eventually producing hypokalemia. So can anyone say, tell me, how does furosemide reach the distal convoluted tubule? Is it via the blood channels? Or is it through the lumen of the loop of Henle? Excellent. So furosemide itself gets filtered, and the action mechanism of action is intraluminal. So that's the reason in patients with renal failure, the dose of furosemide which we need to give is actually higher. So onset of action after giving a IV dose is 10 to 20 minutes. Peak diuretic effect is seen in roughly around 1.5 hours, and 4 to 6 hours is the duration of action. So side effects of furosemide include all of the following except hypokalemia, hyponatremia, alkalosis, and I'm sorry. Yeah, so does anyone want to take a chance? So what's the right answer? Is it number 1, hypokalemia? Come on, anyone? You can't see the question. Okay. Hypochloremia. Excellent. So you have hypokalemia, as we mentioned earlier. So there is a lot of sodium being presented to the collecting ducts, which gets exchanged for potassium, and so you have potassium loss, producing hypokalemia. Hyponatremia, obviously, because that's the mechanism of action, producing sodium loss. Alkalosis, because you have even hydrogen ions being lost in exchange for sodium in the collecting ducts, producing alkalosis, and you get hypochloremia and not hyperchloremia. Coming to the next drug in the diuretic section, so spironolactone. So again, the same options. Does anyone want to take a chance? I think this should be pretty easy. Mechanism of action. Number. I hope you can see the question this time. Is everyone else also having the same problem seeing the screen? So can you see it now? Can you see the screen? Okay, so what's the answer? Right. So you have the sodium potassium hydrogen exchanger present in the distal collecting ducts or the collecting ducts. That's why also labeled as potassium sparing diuretics. So the same thing what we saw earlier, as you can see in the collecting duct where I have put the star. So you have your sodium, potassium and hydrogen exchanger, where this is where your spironolactone or the potassium sparing diuretics act. So what is the mechanism of action? So it basically competes with aldosterone for this channel, and as a result of blocking this channel produces loss of sodium and helps in retaining potassium. So that's why called as potassium sparing diuretics. So hyperkalemia produced by spironolactone can be induced by co-administration with all of the following drugs except AC inhibitors, for example enalapril, angiotensin receptor blocker like a losartan, amiloride and metolazone. So which of these drugs will not produce hyperkalemia with spironolactone? Okay, that's number 4, that's metolazone. Excellent. So all of the other drugs produce hyperkalemia. So coming to the next set of drug, the ACE inhibitors. So we know the mechanism of action, that angiotensin converting enzyme is blocked, so there is no production of angiotensin 2, which is a potent vasoconstrictor, as well as leads to production of aldosterone, which helps in retaining water and sodium, producing increased preload. So the most common drug amongst this group is the enalapril. So indications for use of enalapril include all of the following except number 1, mitral regurgitation, number 2, pulmonary hypertension, number 3, large ventricular septal defect, number 4, LV systolic dysfunction. So which of the following is not an indication for use of enalapril? I hope you can see the questions and the option. It's 8:30. Number 2, very good. So enalapril is essentially a systemic vasodilator. So it's useful in mitral regurgitation because it brings down your systemic vascular resistance. Large BSD for similar reasons, as well as in LV systolic dysfunction. Doesn't really have much effect on the pulmonary system. Side effects of enalapril would include all of the following except hypotension, angioedema, hypokalemia and dry cough. So this should be very easy, I suppose. Hypokalemia, excellent. So as we saw earlier, it should produce hyperkalemia and not hypo. So we usually give a test dose at 0.05 to 0.1 milligram per kg per dose, and we monitor the patient after giving the test dose to watch for hypotension. Once it is determined that the dose is well tolerated, We usually give at the dose of 0.1 milligram per kg per dose every 12 to 24 hourly, up to a maximum of 0.5 milligram per kg per day. Coming to the next set of drugs, the beta blockers. So this is the class of drug which is used in the management of all of the following except systolic heart failure, large left to right shunt, cyanotic spells, and supraventricular tachycardia. Can you see the screen now, or is it still stuck? Now? Yeah. So is everyone able to see the screen now? Okay, great. So does anyone want to answer that? So beta blockers as a group, they are useful in the management of all except number 1, systolic heart failure, number 2, excellent. So large left to right shunts, there is no role of beta blockers in the management of left to right shunt lesions. Systolic heart failure, we know that we use carvedilol in patients with stable systolic heart failure. Cyanotic spells, commonly used drug propranolol, and even in the management of SVT. So carvedilol, the mechanism of action of carvedilol include all of the following except number 1, that it's a non-specific beta blocker. Number 2, that it produces compensatory alpha stimulation. Number 3, it's an antioxidant. Number 4, it's an anti-proliferative drug. So what do you think is the right answer? Anyone? Stuck again? So mechanism of action. So is it a non-specific beta blocker? That it produces compensatory alpha stimulation. It's an antioxidant and anti-proliferative. So which of this is not action of carvedilol? Anyone? Number 4. Number 4. Anybody who disagrees with these answers? Okay, so the answer is number 2, that is compensatory alpha stimulation. So carvedilol actually blocks alpha receptors as well, producing systemic vasodilatation. It is a non-specific beta blocker. It also has antioxidant and anti-proliferative mechanism of action. So carvedilol is contraindicated in all of the following except number 1, bronchial asthma. Number 2, advanced heart block. Number 3, chronic heart failure. Number 4, sick sinus syndrome. Number 3, excellent. So it's actually indicated for chronic heart failure. So the only stage in heart failure where it would be actually contraindicated would be acute heart failure or patients in class 3 or class 4 NYHA stage. So multiple side effects including dizziness, hypotension, headache, vomiting, fatigue, dyspnea, edema, syncope, and worsening heart failure. The dosing, we begin at 0.05 to 0.2 milligram per kg per day in 2 divided doses. It's usually titrated at 1 to 2 week interval to a maintenance dose of 0.2 to 1 milligram. Maximum dose we can give is up to 2 milligram per kg per day. The next drug within this class, propranolol, useful for cyanotic spells. It reduces the infundibular obstruction as well as the tachycardia, which is seen in cases with cyanotic spells, leading to improved diastolic filling. And we give it at a dose of 0.5 to 1.5 milligram per kg per dose every 6 to 8 hourly. Other uses, we use it in cases of SVTs, infantile hemangiomas, thyrotoxicosis, and even in cases of infantile lymphangioma, where latest evidences have suggested a role for propranolol. The next set of drugs, oral anticoagulants. So what is the mechanism of action of warfarin, the most commonly used drug in this subset? So does it prevent fibrin formation, or does it prevent activation of factor 10, or is it because of vitamin K antagonism, or does it activate protein C and protein S? Number 3, excellent. So it basically antagonizes action of vitamin K so that there is no production of vitamin K dependent clotting factors, which include number. Anybody? Which of the clotting factors? 2, 7, 9, 10. Superb. So this is how your warfarin acts. So you can see that factors 7, 9, 10 in the initial stage of the cascade, and eventually factor number 2, which are all reduced by the action of warfarin. So which are the drugs having interaction with warfarin? Phenobarbital, carbamazepine, fluconazole, and digoxin. So which of these doesn't have an interaction with warfarin? Number 4, yes, that's right. So all the other drugs, they have action on the metabolism of warfarin, leading to either increase in the levels of warfarin or in the decrease in the levels of warfarin. And which are the foods you need to avoid while being on warfarin therapy? So rather, which is the food you can take while being on warfarin? So is it broccoli, cabbage, beef liver, or alcohol? Anyone? So is that 4 that you answered, Amitos? Alcohol? Anybody else? Okay, so what's the right answer that you think? Number 3. Okay. Anybody else? So this was actually a catch question. So basically all of these food as well as alcohol you need to avoid while being on warfarin. So broccoli, cabbage, beef liver, they have very high contents of vitamin K. Alcohol now has dual action in a patient who is on warfarin. Acute ingestion of alcohol can actually suppress the warfarin metabolism, leading to increased levels, whereas chronic consumption leads to activation of those enzymes and increased metabolism of warfarin. So the dose of warfarin requirement would go up in patients who are chronic alcoholics. So you start with the initial dose of 0.2 milligram per kilo, and then you repeat the INR. So between day 2 to day 4, if your INR is between 1.1 to 1.3, you repeat the same dose as earlier. If it is between 1.4 to 3, then you give 50% of the initial dose. If it's between 3.1 to 3.5, you give 25% of the initial dose. And if it is more than 3.5, you just hold the drug until your INR drops to less than 3.5, and then you restart at half the dose of the initial dose. And then beyond day 5, if your INR is less than 1.4, you increase the drug dose by 50%. If it's between 1.5 to 1.9, then you increase it by 10%. If it is between 2 to 3, which for most of the indications we would maintain the INR between that range, then you need not change the dose of warfarin. If it is between 3.1 to 3.5, you need to reduce the dose by 10%. And if it is more than 3.5, again you hold the drug until your INR drops to less than 3.5, and then restart at 20% of the dose. So can you get the next drug? So now this drug in the initial trials, it was actually meant for coronary artery disease. But in the cohort in which it was used complained of enhanced penile erections. And suddenly it became a wonder drug for erectile dysfunction. Right. So sildenafil. So what is the mechanism of action of sildenafil? Is it an endothelin receptor blocker, phosphodiesterase 5 inhibitor, prostacyclin synthase stimulator, or is it a guanylate cyclase stimulator? Phosphodiesterase 5 inhibitor. So how do phosphodiesterase 5 inhibitors act? They basically block the reconversion of cyclic GMP to your GMP, and essentially increases levels of cyclic GMP, which in turn activates protein kinase, lowering the intracellular calcium, and as a result producing vascular smooth muscle relaxation. Onset of action is within 30 minutes to 2 hours. Around about 40% is its oral bioavailability. Make sure that the patient doesn't take a high fat meal along with sildenafil, because your bioavailability can be further reduced. And the half-life is roughly around 4.2 to 4.4 hours, and it gets metabolized in the liver. So indications for use of sildenafil include all of the following except PPHN, hyperkinetic pulmonary arterial hypertension, Eisenmenger syndrome, and congenital diaphragmatic hernia. Right. So hyperkinetic pulmonary arterial hypertension is basically your flow-related pulmonary hypertension, which you see in cases of large VSDs, large PDAs. So be careful, because we have seen many cases, small children, young children, 3-month-old, 4-month-old with large VSD who are treated with sildenafil because they have this so-called pulmonary hypertension, where it can actually worsen the condition. The side effects include all of the following except headache, flushing, dizziness, dyspepsia, blurred vision, and increased bleeding tendency. Number 4. Okay, I'm sorry. So again, this was the catch question. So all these are side effects of sildenafil, including increased bleeding tendency, because your sildenafil acts even on your phosphodiesterase 6, which is a receptor within the platelets, producing decreased platelet aggregation, and as a result producing increased bleeding tendency. Headache, flushing, dizziness because of systemic hypotension, dyspepsia because it relaxes your lower gastroesophageal sphincter, and blurred vision because your phosphodiesterase receptors are even present in the posterior portion of your eye or in the retina. So which are the other phosphodiesterase 5 inhibitors in use? Can anybody name them apart from sildenafil? Tadalafil, That's right. And vardenafil. So what is the advantage of tadalafil over sildenafil? Excellent. So it requires a single daily dose administration. The next set of drug, the commonly used drug, what we use apart from sildenafil is bosentan. So what is the mechanism of action here? Same options again. Right. So it's a endothelin receptor blocker. So as you can see on the left half of this picture, excuse me. So you have your endothelin pathway where the pre-pro-endothelin gets converted to pro-endothelin, leading to formation of endothelin 1, which via action on endothelin A and endothelin B receptors is a potent vasoconstrictor and a pro-proliferation drug. So bosentan, basically it blocks both your endothelin A as well as endothelin B receptors and leads to vasodilatation and has anti-proliferative action. So side effects of this include all peripheral edema, systemic hypotension, fatigue, increased liver enzymes, which is seen in roughly around 10 to 11% of cases. Other endothelin receptor antagonists include ambrisentan, which is specifically a endothelin A receptor blocker, as a result of which it also produces vasodilatation and has anti-proliferative action. And ambrisentan does not produce much of elevated liver enzymes as compared to bosentan. Then you have sitaxantan and macitentan. So I hope that all of you are not asleep at the end of this lecture or other quiz. And I apologize for the kind of technical issues we had during this. Any questions, I would be happy to answer for that.